Good morning. We would like to welcome our audience. We would also like to welcome our Facebook audience. And what we're going to do this morning for you is, over the next half hour, do a dissection of the thorax. So we have a specimen that's in the supine position. We've marked out some of the landmarks that we're going to use to take off the anterior wall of the thorax. For example, the clavicles. We have the sternum, and then we have the costal margins here. So we're going to, over the next 5 or 6 minutes, open up the thorax and then look inside. And we'll be the first humans ever to look inside this person's thorax in this way. So we've already made little incisions along the lateral mid-axillary line. We're going to make incisions over the clavicle, over the costal margins. We want to be careful with the costal margins that we stay on top of bone so that we don't dip off into the abdominal cavity. What I like to do is, once you find the costal margin here, then dip your fingers inside and you'll feel where the attachment of the diaphragm is. That way we've developed a plane. And most of the older specimens you can get away with opening the ribs just with a pair of heavy scissors. So we'll come across just at the xiphoid, so I'm cutting through the rectus abdominis muscle now. For those in the audience that aren't anatomically oriented, that's the muscle that you try to exercise with sit-ups. And if during this you have any questions, feel free to shout them out. This is an adult female, if I didn't say that already. Tyler, can you come over here and cut up the ribs through that incision for me? So I'm cutting across, connecting the midline. So now both medial clavicles are exposed. And one way to think about this is basically we're going to lift up the hood of your car here in just a few minutes. And that gives the viewer, the student, etc., a good anatomical perspective of how things are arranged just beneath the anterior thoracic wall. Let's see. Okay. So at first glance, this is a very healthy thoracic cavity. Let's do this, Tyler. If you can just tie that off somewhere back there so it doesn't fall. Very healthy intrathoracic contents, and some of the things we see, I'm putting my left hand here on the right lung, and the lungs are still aerated. And I always tell the students it's interesting because the air that's in this lung now would have been the last air that this patient breathed in before they passed away. So air here in the lung. We can move this aside just a little bit to give you a better view. Here we see some fat in the midline. We're looking into what's called the anterior mediastinum. And as we go more posteriorly, we start to run into the middle mediastinum, which is where our heart lives. So some of this fat we're going to tease away. You can start to get a little hint here that there's a membrane, right? And this is called the pericardial sac, and that's what the heart lives inside of. Normally there's a little bit of fluid there just to decrease the friction every time your heart beats. This is our left lung, and we're going to swing the left lung over just a little bit. Some more fat. You can see the edge of the diaphragm. So most people expect the diaphragm to be this thick, robust muscle, and it's actually extremely thin. And if I pull apart and hold the diaphragm, I'm holding the entire thickness of the diaphragm here. So it's almost paper thin. And in some places you can even see underneath it, see through it. So everything in this region is going to be in your abdomen, and everything above the diaphragm is in the thorax. So for our next procedure, we're going to remove the rest of this fat. Some of the fat up in the superior part of the mediastinum here is going to be related to the thymus, which is involuted in most adults. And up at the apex here, we see some large veins. These are the biggest veins that you've seen in the thorax so far, even though we've gone through a few others. And these make up the brachiocephalic vein. So this is the left brachiocephalic vein. We have a right brachiocephalic vein, and these basically drain the upper limb and also drain a lot of the contents from the intracranium. And they're coming together just here, and this is our superior vena cava. So most of the blood from the upper half of your body gets back to the heart through the superior vena cava, which is just here. We can also appreciate the aortic arch. So this is coming from the heart and then giving off various branches to the surroundings. So for example, this is our first branch of the aortic arch. This is the brachiocephalic artery, and this is going to split on the right side into the right subclavian and also into the right common carotid artery. Our left common carotid artery is going to come off separately, just here. And then around the corner, we get a peek at the left subclavian, which is here. You also note, just passing over the aortic arch at this location, there's a fairly prominent nerve, to give you an idea what some of the nervous tissue looks like. And this is a branch of the vagus nerve, left vagus nerve. And as that left vagus nerve crosses over the aortic arch, it's going to come back and recur as one of its major branches just at the level of the junction between the pulmonary artery and the aortic arch, and that's the left recurrent laryngeal nerve, a nerve that's very important in your laryngeal muscles. One reason that thoracic pathology can result as an early symptom of hoarseness is that it presses on that recurrent laryngeal nerve in the chest, either hoarseness or manifest as a cough. So our next step is, let's open up this pericardial sac. And as we do that, we'll see that running on the lateral aspect of the pericardium on both sides is our phrenic nerve, which is in this fatty tissue. So right and left phrenic nerves. And it's these phrenic nerves that go down and innervate your diaphragm, right? And they come from the neck. So a nerve from the neck runs all the way through the thorax and innervates the diaphragm. The interesting reason for that is that the diaphragm embryologically grows up in the neck and gets innervated there, and then it drags itself and its nerves down into the thoracoabdominal junction later in life. So we're going to pick up the pericardial sac, make a little incision, cut open. And we see a heart that's somewhat enlarged. I'll pull this out for you. A little bit of enlarged heart, fairly normal epicardial fat for this age. If we pick up on the underside, you can see the inferior vena cava, which only has a short segment in the thorax, just here. A little bit of blood that's in the back of the pericardial sac. This is the apex of the heart. And here again we see the ascending aorta. Here's our superior vena cava, our right atrium, our right ventricle. This is the pulmonary artery. And then the pulmonary artery is on the side here where we see the left ventricle, left atrium. So get a better view of this, and so we can also look at some of the internal anatomy of the heart. We need to disconnect all the plumbing, and the plumbing that you have to disconnect, we have to identify the inferior vena cava here, and we just come across this. There'll be a little blood that comes out. Superior vena cava. We'll come through the aortic right here. And this is a healthy aorta. There's not a lot of plaque disease within it. Here we have the pulmonary artery. The pulmonary trunk will come across. Now the only thing holding the heart in place are the pulmonary veins that are coming in back to the left atrium. So as we pull the heart toward us here, we can come across those. You have a blue towel, Jason? Or some suction? So these specimens are fresh specimens. They're not embalmed, so they still have blood within them. Maybe Hey, Rod. I'd like to welcome our VIP guest to the lab, Dr. Rod Esculian.
Hey guys, how's it going?
Who sends his greetings to our audience. You want to see if you can work on that. So while Tyler works on some blood removal there, I'm going to open up the heart and show you some of the different structures that we see. So again, just to orient you, here's the ascending aorta. We've cut through the superior vena cava, and what I want to do is come up through the right ventricle. And I'll go up into the right atrium. And the first thing you can see in the chambers are these chordae tendineae. People refer to those as the heartstrings. And we see they're attached to little muscles that live down in the ventricular cavity. These are papillary muscles. And the ancient Greeks thought that these looked like little nipples, hence the term papillary. And from those papillary muscles, we see the chordae tendineae. And they go up and attach into this valve. And these are the atrioventricular valves. And on this side, right side, this is the tricuspid valve. There are 3 leaflets that are usually seen here. So in this region, we see if we can see it on the screen, this is the right ventricle, where my finger is. And then just above that, here's the right atrium. And if you look especially closely in the right atrium, you see several things. You see components of the cardiac venous system that are coming back into the right atrium, so through the coronary sinus. We see openings that take us in the fetus across the midline and into the left atrium, but then seal over, and that's called the foramen or the fossa ovale in the adult. We see the superior and the inferior vena cava that are coming inside the right atrium. So the blood, for those that aren't familiar with this, the venous blood that doesn't have oxygen is coming back into the right atrium, right? So from the superior vena cava, most of the upper half of the body, inferior vena cava, lower half of the body, from the cardiac circulation itself through the coronary sinus, it comes into the right atrium. It then is brought down into the right ventricle, and from the right ventricle, the blood flow is going to come up through our pulmonary trunk, or our pulmonary artery. This then goes to the lungs through the left and right pulmonary arteries and is oxygenated in the lungs. And then that oxygenated blood is going to come back through our pulmonary veins, which we see on the posterior aspect of the heart. And they bring blood that's now oxygenated back into the left atrium. And from the left atrium, that blood, we'll do this with the knife, is going to go into the left ventricle. And the first thing you'll notice is as we start to look in the left ventricle compared to the right ventricle, the wall, the myocardium, is much thicker. I don't know if you can appreciate that, but this is a thicker myocardium, and it's thicker because it has to propel blood to the entire body, so not just to the lungs. So myocardium, we see a beautiful papillary muscle here, some chordae tendineae, and these are attached to a valve, and on this side, this is referred to as the bicuspid valve. This is the apex of the heart, and that rests at about the 5th intercostal space if you're looking at external landmarks. Let's show you a coronary artery. Tyler, can you grab something and hold on to that for me?
Right here?
Right here. We're going to truncate the aorta just a little bit. And here is our left coronary artery. So left coronary artery, right coronary artery across the way here. And I don't know if you can see or not, but if you look down inside the aorta, you can see the aortic valves, aortic semilunar valve. And these valves during diastole will fill with blood, come to the midline, and occlude additional blood from going down inside the ventricle. So that's a quick dissection of some of the major structures of the heart. Let's draw our attention and look on the inside and see if we can find some additional structures of the thorax. So just to orient you, here's our aortic arch. We've already discussed the branches here, and we're going to come behind the aortic arch and the first thing, if you can look in the very floor here, this is your esophagus. So the esophagus ends where the pharynx ends where the esophagus begins at C6, and then this is its course through the thorax, and then the esophagus is going to enter the diaphragm here at about the T8 vertebral level. T10. We're going to pull the esophagus over. And now we're looking at the continuation of the aorta. So we saw the aortic arch above, and here's the descending thoracic aorta. Now if we look just to the side of that, we'll see a hint of a vein. This is called your azygos vein. It's one of the large veins other than the vena cava in the thorax. And the azygos vein collects blood from primarily the intercostal spaces and then brings that up to the superior vena cava. This is a little structure that lives in the thorax that you can see running over the tip of the scissors, and this is the thoracic duct. And the thoracic duct drains the majority of lymph from the body and returns it to the venous system, and does so usually primarily on the left side of the neck, and returns it at the junction between the internal jugular and subclavian veins. So if we move thoracic duct out of the way, we move aorta out of the way, this will give you a perspective of the anterior bony anatomy. So we're now looking down on the anterior vertebral bodies, but through the anterior longitudinal ligament. So here's bone. And you can see pretty nicely there's an intervertebral disc that's a little lighter color here, and that you can actually plunge the scissor tips into. The ligament on top, again, is anterior longitudinal ligament that inhibits excessive extension of the spine. Now you can see why it's difficult to get to this segment of the thoracic spine for procedures that would need to be done here, and the fact being that the heart's in the way. Let's take out one of our lungs, and the way we do that is we just simply dissect down medially and toward an area called the hilum of the lung. And this hilum is where all of the various arteries, veins, and breathing tubes are going to come inside and join. I'd like to show you first a little hint of your trachea. I think you can see that. So you can see the trachea here, and the hemostats holding on to the right mainstem bronchus. Here's our left mainstem bronchus, and you can note there's some lymph nodes here that sit between the two primary mainstem bronchi, and those are called carinal lymph nodes. Often those will fill with disease from the lungs, for example, cancer, and the bronchi, as those nodes start to enlarge, will start to move away from each other. But you get a hint of these hyaline C-shaped cartilaginous rings that are not present on the back of the trachea. And they go about 3/4 away around the edge. We'll pull this over. So now we're really disconnected. We've already disconnected the pulmonary arteries, veins, and now the bronchus, so the lung can come out pretty easily. So this is a normal right lung. I'm going to put a towel down there. Just like that? Yeah, great. And as most of you know, the right lung normally will have 3 lobes. We see a superior, middle, inferior lobe. There's a little darker component of the lung here, and that's just the gravity pulling the blood that's inside of the lung posteriorly in this supine cadaver. Various fissures that separate the two. And then if we look at the hilar component, we can see the bronchus that's been cut here. You can see the pulmonary veins and arteries. And specifically, you can see some hilar lymph nodes that are here. And this area of the bronchus is very sensitive to compression. So these hilar lymph nodes early on in disease, for example, lung cancer, as they start to enlarge, can press on that regional bronchus and give you a cough. So one of the first things your doc's going to ask you when you go to see him is, have you had any new onset cough? And it could be due to these hilar lymph nodes being enlarged. So the hilum For regional landmarks, the phrenic nerve, if you remember that, ran in the anterior part of the hilum, just in front of it. The vagus nerve runs just behind the hilum. We'll remove this. And I want to show you the posterior region of the thorax. So if you can see, this is the diaphragm that's bulging up into the thorax. And the reason for the bulge is the underlying liver. So if we were to cut through the extremely thin diaphragm, just like this, give you a hint of the liver underneath. So that's the right liver, right edge of the liver. If you look down in the floor here, you can see the ribs, right? We see the vertebral bodies. And Tyler, if you can hold that liver toward you just for a minute. And if you notice this glistening, shiny material, right? That shiny material is the pleura, and the pleura has two parts. It has a part that covers the wall or the inside of the thorax, so it's parietal pleura. And then we have visceral pleura, which gives the shininess, shiny coat to the lung itself. So we can take the pleura here, and we can undermine it. Now the parietal pleura is exquisitely pain sensitive. So if you put tubes or any other intervention into the thoracic cavity, and by necessity when you go through the parietal pleura, that's a very painful procedure. If you could go directly to the visceral pleura, then it's pain insensitive and you don't feel anything. So this parietal pleura, if you've had pleuritis before, or pleurisy, you've heard of those terms, this is the structure that's involved. So we're going to move that off. It's also the layer that if we have any barbecue aficionados in the crowd, that you have to remove from the ribs so that the seasoning can get down to the meat. If not, it's prohibited by this parietal pleura. So here we see the intercostal spaces. So here are our ribs on the back. And running in these intercostal spaces, we have more or less 3 layers of muscle. The intercostal muscles help us move the ribs. And then in the intercostal space, you'll also find that you have intercostal veins, you have intercostal arteries, and you have intercostal nerves. So there's a little neurovascular bundle running underneath the scissor. And it's interesting, in the thorax, the veins, arteries, and nerves, they run in that same type of arrangement. So the veins are most superior in that little bundle, then the artery, then the nerve. So that clinicians who want to anesthetize these nerves before they put in a tube to drain the thorax, like a thoracostomy or any other procedure here, will remember the relationship between these vessels and nerves and try to approach them accordingly. Now, as we look up in the superior part of the thorax, we can palpate the first rib. We see our right brachiocephalic vein. Remember, I told you that's draining the internal jugular and the subclavian vein. And you can palpate just above that. So my finger's now leaving the thorax and going above the first rib, and I'm now inside the neck. So that shows you the relationship between the neck and the thorax. So everything, more or less, that leaves the thorax has to traverse up into the neck or up into the upper extremity. If we look on the back of the chest cavity, this will be our last little segment. The hemostat, remember I've grabbed the xiphoid process. That's part of the sternum and moved that up superiorly. We're looking at the back of the sternum. So we fractured the sternum here at about the junction between the body and the manubrium of the sternum. And that's where your second rib comes over, so that's a good landmark. And I'll show you quickly, there's a vessel that runs on either side of the sternum, and this is called the internal thoracic vasculature, and you have both an artery and a vein. And here's our artery, so internal thoracic artery. This comes from the subclavian artery and then supplies the back of the thoracic wall, and then goes down and also continues to supply some of the diaphragm. And interestingly, clinicians will often take this, usually the left side, and they will skeletonize it as far distally as they can, usually toward the xiphoid, cut it, and then reflect it, and then sew that into the distal part of a stenotic area of a coronary artery. So the term left internal mammary, which is an older term, artery bypass. So back of the sternum, and you can see you could access that with a median sternotomy pretty easily and gain access to these vessels. This is the back of the rib cage, and we see some muscles. These specialized muscles that you only see in the anterior part of the rib cage are called the transversus thoracis muscles. Big, broad muscles. And then here we see some of the intercostal musculature that I mentioned to you before, just here. Okay, so that's a quick review of some of the very major structures of the thorax, heart, lung. Obviously, you can go into more detail. This is just serves as a primer for someone that may not be in this field. And I'd love to take any questions if you have them. And if you don't have questions, you're welcome to come over to the lab directly and look at these a little closer up.